from Department of Psychiatry, National Cheng Kung University, Taiwan. Our symposium topic is schizophrenia and depression. It's my pleasure to introduce our speakers. The first speaker is Dr. Naron Ro. Dr. Ro is an MD and PhD. He completed his training in psychiatry specialist in National Institute of Mental Health and Neuroscience. He also completed his postdoctoral fellowship at Research Imaging Center for Addiction and Mental Health, University of Toronto, Canada. He is now working as additional professor of psychiatry and involved in clinical care training psychiatry, postgraduate students and research. Dr. Ro's research team is interested in studying neurobiology of cognitive deficits and metacognitive deficit in schizophrenia by using multimodal imaging techniques. His team has done impressive work in studies of fMR and PET studies. Today, Dr. Ro will give us a talk about neuroeconomics and imaging to understand the neurobiology of social cognitive deficit in schizophrenia. Let's welcome Dr. Ro. Dr. Ro? Dr. Naron Ro?
Yeah, hi. I sent my presentation, which was recorded. I'll be present and happy to answer if there are any questions. Can you hear me?
Yes.
Yeah. I have already sent my presentation as a video.
Good morning. At the outset, I thank the organizers for the invitation. My title of my talk today will be Neuroeconomics and Imaging to understand the neurobiology of social cognitive deficits in schizophrenia. So in the next 15 to 20 minutes, I'll try to cover this topic and then I'll be happy to take up any questions that comes up to that. So what we already know in schizophrenia is that there are positive symptoms and there is an increased dopaminergic activity in the mesolimbic pathway which results in positive symptoms. Then there are negative symptoms, and it is proposed that the decreased dopaminergic activity in the mesocortical pathway, this results in the production of the negative symptoms. While the pathophysiology of the positive symptoms is very well understood, the pathophysiology of the negative symptoms and the cognitive deficits are relatively less examined. Recently, few studies, including one of our own studies, have suggested that there is an impairment in the prefrontal cortical dopamine release, and this change results in production of the negative and the cognitive deficits seen in schizophrenia. However, we all know that schizophrenia is not a single entity. Though we call it as a single entity, it's a collection of multiple group of symptoms, and there is not a single schizophrenia, but there is a group of schizophrenias. So for the convenience and for better understanding, they can be divided into different dimensions. So one of the well-known dimension is the positive symptom, and then there is negative symptoms. There are also affective symptoms and the cognitive deficits. And the cognitive deficits can be divided into neurocognitive deficits as well as social cognitive deficits. Though the pathophysiology of positive and negative symptoms are proposed, the pathophysiology of the social cognitive symptoms and the affective symptoms in schizophrenia are not that well examined compared to these symptoms. And it is also possible that the pathophysiology of the social cognitive symptoms may be different compared to the pathophysiology of the positive and the negative symptoms seen in schizophrenia. While the role of dopamine is well established in positive and negative symptoms, the dopamine may not have a considerable or a significant role in social cognitive deficits, and there may be other players other than dopamine in the production of the social cognitive deficits. So researchers have been trying to see what are all the other molecules that may be playing a role in the social cognitive deficits. Why social cognitive deficits are important is that social cognition forms one of the core determinant of our social behavior. Though positive, negative, and cognitive symptoms are also important, a major chunk of the social behavior is actually determined by the social cognitive deficits. And the social behavior is something which is a key determinant of the functional outcome. So, if we are expecting the patient with schizophrenia to recover from the illness and get back to the community and work optimally in the society, uh, the person's social behavior need to be appropriate, and to have an appropriate social behavior, the person need to be treated and recover from the social cognitive deficits. However, studying the social behavior in a lab setting is not simple. It's very challenging, primarily because human social behavior is an interactive entity. So, when we speak of social cognitive deficits, it's not the performance of one individual, but the human social behavior requires two individuals, the person and the person with whom this individual is interacting. So, this failure to mimic a real world social interaction actually results in failure to evoke real behavior. So, this may not allow one to examine the social behavior in a lab setting in an optimal manner, because the response of an individual depends on both self and other. So it's not only the status of me, but it is also the response of the other person, which actually determine my response in the subsequent behavior. So let's take an example. For example, if two individuals are interacting with each other, then I need to perceive what the other individual is trying to convey and interpret the individual's behavior, and then I have to generate an optimal response depending upon the other person's behavior and the intention and the meaning the other person is trying to convey. So, in a social response or in a social decision making, it is not only my choices, but it is also the choices, intentions, and the behavior of the other person, which determine whether my response in that social context is going to be competitive, cooperative, or I'm not going to cooperate with the other individual. Okay. So this kind of an interactive social behavior is not uh, tapped by the traditional neuropsychological assessments. The traditional neuropsychological assessments developed through a lesion-based analysis, and hence they may not be appropriate for examination of the interactive nature of the social behavior. So, to analyze this kind of an interactive nature of the social behavior instead of a neuropsychological approach, one may have to go for a multi-domain behavioral neurosciences based approach. A model which can be used for studying behavior, especially the social behavior in a lab setting, is neuroeconomics. So, the neuroeconomics combines principles from cognitive and behavioral neurosciences and importantly behavioral economics and game theory. These two elements actually bring in the real world behavior, because money is known to bring about a real world behavior in an individual even in the lab setting, and of course it has a significant bearing on the and significant involves the experimental psychology principles. So it's the combination of the cognitive and behavioral neuroscience, behavioral economics, game theory, and experimental psychology, which results in neuroeconomics. And we believe that the neuroeconomics is one of an attractive alternative to study social behavior in lab setting. So I will be discussing about two specific elements today. Okay, so I'll be discussing two tasks which we have recently analyzed. So, the decreased social cooperative behavior, or in other words, a few people also propose paranoia is due to increase in self-interest and decrease in the trust in others. Many studies have tried to examine these two elements separately. Okay, so first I will be discussing about the trust behavior in schizophrenia, and then I will discuss about the social cooperative behavior in schizophrenia. The focus with these tasks, especially with the neuroeconomics and the social behavior, has been on neuropeptides because oxytocin and vasopressin are known to influence social behavior across species. And oxytocin gene knockout mice loses all the social functions, which is actually restored by oxytocin. And the wolves, which have mutations in the oxytocin receptor, have significantly different social behavior. And human studies in healthy volunteers have also shown that oxytocin significantly influences the social behavior in humans. We examined the effect of oxytocin in patients with schizophrenia using a pharmacological MRI approach. So we combined the principles of pharmacological MRI and neuroeconomics. So each individual undergoes two scans. In one scan, the individual is administered oxytocin intranasally. In the other scan, the individual is administered placebo intranasally. And in both the scans, they perform the neuroeconomic game. And then we analyze the behavior as well as the individual's response in terms of the brain change using the neuroeconomics game and the MRI combination. So this is the game that we asked the individuals with schizophrenia and healthy volunteers to perform. So this is a modified trust game, which is a well-established game to examine the trust behavior. So in this game, the experimenter gives 12 money units to the participant, and then the participant plays the role of a truster, and then they have the option to trust the other individual and share an X amount of money. Either they can share all the 12 money units with the other individual, or they can share 4 or 8 money units, or they can keep everything to them and then they may not share anything to the other. Whatever the individual shares is doubled and then is given to the trustee. Now the trustee has an option to reciprocate the trust by transferring back half the money units so that the truster also gets benefited, and or the trustee has the option not to transfer back the money unit. So the behavior of the trustee is informed to the truster, but at the same time truster has no control over the behavior of the trustee. So there is a chance that the truster may trust the trustee more than required and may lose the money, or at the same time, if the truster doesn't trust the trustee, then they may not invest any money, and at the end of the day, they may not be gaining much money out of the whole experiment. So that there is a chance of reciprocation of the trust, or there is a chance of betrayal of the trust. So if both individuals trust each other and then the trustee reciprocate the trust, then both of them get benefited. Otherwise, only the trustee gets benefited. So this game was played by both patients with schizophrenia as well as healthy individuals. And then what we could see was that when that feedback was given to the individuals, that the trustee has reciprocated back in 50% of the trials, but not in the remaining 50% of the trials, the individuals with schizophrenia had significantly decreased levels of money invested in the trustees, whereas the healthy volunteers continued to invest money even after giving this feedback. So as you could see in this table, there was the total amount of money invested by the healthy volunteers was considerably higher compared to patients with schizophrenia, and this was particularly significant because of the feedback. So that this indicates that we hypothesize that the individuals with schizophrenia are extremely sensitive to betrayal as a feedback. So betrayal aversion may be one of the reasons that these individuals can significantly decrease the amount of money invested. So interestingly, patients with schizophrenia also had higher activation of bilateral superior medial prefrontal cortex and left insular cortex and compared to healthy individuals. As you know, these are the brain regions which are part of the social brain, and this region, especially the left insular cortex, is a region which is very important for betrayal aversion and the negative effect associated with the betrayal. So the brain changes actually give further evidence to the existing literature that the patients with schizophrenia may have alterations in the functional brain activity in social brain regions. On administration of the oxytocin, there was higher activation in premotor cortex and the visual association cortex. Both were corrected for multiple comparison. Um, However, we could not see a behavioral change with a single dose of oxytocin administered intranasally. So there was no difference in patients between the placebo condition and the oxytocin condition in the total trust, or it did not have a significant effect on the trust after feedback. So this suggests that though there are some brain functional brain activity changes with oxytocin, this failed to translate into um, an observable behavior in patients with schizophrenia. So multiple reasons are possible. So one could be that the single dose administration may not be sufficient to bring about the changes in the behavior and may require a long-term administration of the oxytocin. The second possibility is also that the patients with schizophrenia may require a higher dose of oxytocin to result in observable behavioral changes. So, because recent studies suggest that patients with schizophrenia may actually respond better to 42 to 48 units of oxytocin. But in this study, we administered 24 international units of oxytocin because that's the standard dose of oxytocin that had shown response in healthy individuals in previous studies. So now switching gears, I would like to take you through another experiment. And this experiment we tested another cognitive entity called risky cooperation. So people cooperate with the other individuals when the situation is conducive, but human beings are evolutionarily have cooperated even in situations which are risky. So hunting gives an ideal example, which is a ideal example for risky cooperation. In hunting, unless the partner cooperates with the individual, there is a risk to the individual that they may lose the prey one, or worst case scenario, they may get attacked by the prey. So in this scenario, the individual need to trust the other and also has to make a choice whether they go for a bigger prey, expecting the other individual also to cooperate, or they go for a safer option in which they go for a smaller prey, so that regardless of the partner being cooperative or not, they will be able to get some benefit out of this. So in the neuroeconomics counterpart of the hunting, there is a game called as a stag hunt game, okay, which is played between two players. And we examined the risky cooperative behavior in schizophrenia using a modified stag hunt game. And based on the previous literature, we administered vasopressin and used the same methodology in which in one trial they receive patients receive placebo, and in the other they receive vasopressin, and patients and the administrators are blind to the drug administered to avoid the bias. So in stag hunt game, if both players go for a bigger payout, then both get higher payout. So for example, if they both go for stag option, then they get 200 money units. Whereas if they both go for rabbit, they get a lower payout. If the participant goes for the stag and the partner goes for the rabbit, then the partner gets the lower money amount, whereas the participant gets no money. So we made use of this principle in which the participant has the option to go for either a stag or a rabbit, okay, but and varied the amount of money that they are going to get if the participant goes for the rabbit and the partner goes for the stag. Okay, so they were told that they are going to get one of these, and in each trial they were given that the different options for the rabbit, and they were asked to choose whether they go for the stag option or whether they go for the rabbit option. And we calculated a level known as the security level. So that's the level at which the player switches from the stag option, which is the risky cooperative, to a rabbit option, which is the safer option. Okay. So the stag hunt game, the security level, both before feedback and the after feedback, the feedback was primarily what was the security level that the partner chose. Okay. So it showed that patients with schizophrenia had significantly lower security level compared to healthy volunteers, suggesting that patients actually have lower risky cooperative. However, this is not a general trend because it is not because of the inherent risk-taking behavior in healthy volunteers, because on examination of a general risk-taking tendency, that is, we ask them to just play a lottery with the money given to them. Patients with schizophrenia actually had higher general risk-taking tendency compared to healthy volunteers, which suggests that the deficit is actually specific and patients have lower risky cooperative behavior compared to healthy volunteers. But on administration of the vasopressin, we again did not see any major difference in patients' behavior. So there was no difference between patients and controls in the security level either before or after feedback. But at the same time, there was an increase in the general risk-taking tendency, which was borderline significant with vasopressin. So to summarize, compared to healthy volunteers, schizophrenia patients have decreased trust in others, and they have increased self-interest, and they also have decrease in the cooperative behavior. So these are present in treated schizophrenia patients, suggesting minimal role of dopaminergic antipsychotic on these behaviors. They could influence the real-world functional outcome. Single-dose oxytocin resulted in changes in brain activation while performing trust game, but there was no change in behavioral measure. In a similar way, there was no change in the stag hunt game. However, we have also done another game called as dictator game, and it has shown that there is an significant increase in altruism. In the interest of time, I was not able to walk you through the dictator game. However, if somebody is interested, I will be happy to answer any questions. So pharmacological MRI in combination with neuroeconomics is a potential design to examine the effects of neuromolecules, and single-dose neuropeptide results in improvement in behavior or brain activation. So there is a potential for add-on treatment in schizophrenia, and repeated administration may provide better effect size. Single-dose studies can provide valuable information regarding the behavior to be targeted, and this data helps to design and outcome measure of a clinical trial. So dose titration and long-term safety is to be established, with which I'm hopeful that we may be able to try these new molecules as add-on treatment in schizophrenia and related psychosis. So I thank all my funding agencies and my collaborators and my team, which has been the backbone of all the work. Thank you for listening to my talk. Thank you.
Okay, thank you, Dr. Luo. The second speaker is Professor Goram Mahan Khan. Dr. Khan is an associate professor and the executive director in Research Center of Pokhara University and School of Health and Life Science, Department of Pharmaceutical Science, Pokhara University, Nepal. Today, Professor Khan is going to talk about the patterns of prescribing psychotropic medication in western region of Nepal. Let's welcome Professor Khan video, and then we will play the video.
Mr. Chairman, speakers, guests from abroad, guests from Taiwan. Thank you, organizer, for giving me this opportunity to participate in second international conference of REB AMP My topic of the presentation is drug utilization patterns and a study of quality of life of patient taking antidepressant drugs in outpatient psychiatric department of Western region of Nepal. This is my university. Mental health in Nepal. Nepal is the country full of different cultures and traditions, but when it comes to mental illness, each of these cultures shares the same concepts in Nepal. Most of the people think that suffering from mental illness is the same as being mad. Even patients with neurotic disorders do not like to consult the mental health professional because of the stigma of mental disease. Although Nepal's constitution regards as a basic human right, the system definition of the health and its exclusion of the psychological care has led to a faulty understanding of this right, and the Nepali healthcare system neglects this aspect of people's healthcare treatments. In terms of financing, less than 1% of healthcare expenditure by the governments are directed toward mental health. There is some strains. Despite of challenges, attention to mental health in Nepal is increasing. The country has the national mental health policy. In addition, there is a network within a general health service system where the mental health care can be integrated. There is the gradual increase in awareness of the mental health program. Psychiatric drugs are widely available in all the levels. Though there is some challenges. Some challenges are lack of adequate mental health professional and treatment facilities. There is only one mental health hospital in the country, and the mental health services are not easily available in rural and remote area. Mental health infrastructure is poor. Government structure to address the mental health are not yet in place, although legislation is planned. There are no consumer or professional organizations that advocate for the mental health issues. With this, we have decided to go with these topics. So my topics contents are introduction, objectives, methodology, result and discussion, conclusion, acknowledgement and reference. Drug utilization study. There is rational prescriptions ensures the safe, cost-effective use of medicine, and its adherence leads to the success of treatment therapy. The present study was carried out to analyze the prescribing pattern of psychotropic drugs, its utilization, and adherence in psychiatric patients. Quality of life also measured in this study. So the quality of life of patient is defined by the WHO, individuals' perception of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. Rationale of the study. Inappropriate prescribing habits and medication non-adherence is the most common cause of mental health problem, which leads to the decrease in quality of life of patients. In Nepal, limited numbers of studies have been carried out related to this topic, so the exact prescribing habit of the psychotropic drug is not known. This study is expected to analyze the prescribing pattern of drugs to patients suffering from a mental disorder. Similarly, this study helps to find out the medication adherence among the psychiatric patients. So that this study is carried out in western region of Nepal. Objective of my study. There is a general objectives and a specific objective. A specific objective we have following: to analyze the drug utilization patterns, to identify the drug prescribed from the essential list, to identify the best treatment strategy, to determine the average number of drug prescription, identify whether the drugs are prescribed in generic or brand name, to study the quality of life. Methodology. This is a single center studies and patient visiting the busy hospitals in Pokhara. Study duration is 1 month. Sample size is 100. We have taken the consent for the ethical approval from the Pokhara University Research Center. It is a review committee. We got it the ethical approval. So there is tool used for these studies, socio-demographic profiles and the data collection for all the things given in the prescriptions. Conceptual frameworks. At the information: name, age, sex, occupation, religion. Then the antidepressant drugs prescribed were divided. and education, name of the prescribed as generic, and drug name, frequency of the drugs. These are things are noted in the performa. Measure of the quality of life. The SF60 questionnaires model was used to determine the measure the quality of life. These are the results. If you can see, mostly majority of the patient is 35, belongs to the age group of 31 to 45 years, followed by 26 and 25 in the age group of 16 to 30 and 46 to 60 years respectively, which has been shown in the figure 1 in this figure. Similarly, among the 100 sample size, total number of female patients was 54 and male patients were 46. Similarly, it was found that different religion has also affected the depression. Majority of the patients were of Hindu religions, 86%, followed by Buddhist and Christianity, and 12% and 2%, which has shown in these figures. Similarly, it was found that the profession also has affected the depressions. Majority of the depressive patients are housewife, 38 in number, followed by the job holder and unemployed, 17, and 12 farmer was found to be suffered from depression, less in number, less than 5, which has been shown in figure in this. Similarly, according to the level of education, higher secondary students were more suffered from the depression than others, followed by illiterate, literate, bachelor, and primary education levels shown as in this table. Similarly, drug utilization patterns of antidepressant drugs. Among the psychotropic medicines, antidepressant drugs was most commonly prescribed by 34%, followed by benzodiazepines, anxiolytics, antipsychotics 31%, 28% respectively. Anti-epileptic drugs was prescribed in least number, 3%. Also, it was found that other drugs like proton pump inhibitors, rabeprazole, pantoprazole was prescribed. During this study period, it was found that average number of drugs per prescription was 3.28. All the drugs were prescribed in brand name. The popularity of the antipsychotic medicine prescribed has been shown in this figure. Among the different classes of antidepressant, SSRI was prescribed more commonly for 60% of patients, while AS and TCA were prescribed by 35% and 5%, which has been shown in this. Similarly, it was found that among the antidepressant drugs, Mirtazapine, which belongs to AS, was found to be prescribed by 31%, followed by fluoxetine and quetiapine, which belongs to SSRI, were found to be prescribed commonest by 23% among the individual. Antidepressant drugs prescribed and other escitalopram and sertraline were prescribed by 17%, and 11% other antipsychotropic drugs, anti-anxiety drugs, pantoprazole, rabeprazole has been prescribed by 20%, which has been shown in this figure. It was found that among the prescribed antidepressant drugs, essential drugs were used in 31% of the cases of depression. Non-essential drugs were used in 69%. The drugs that are included from the essential drug list of Nepal are fluoxetine, amitriptyline, which has shown in this figure. Similarly, quality of life of depressive patient. The result of QAL of patient according to the medical adherence has been determined by the mean standard deviation. The medical adherence of quality of life of patient has been compared between male and female. According to the observation, the medical adherence has been good in male than female, which has been shown in this. Physical function, the result of quality of life, depressive patient, male and female, according to the Physical function is determined by the mean standard deviation. The physical function, mental health, mental vitality, social, and had been obtained as this. It was observed that the comparison between male and female, the mean of physical functioning is higher than the male is 2:1, but all the variables of mental health, RE and RP, bodily, mentally, vitality, social, had been higher in male than that of female, and the results obtained were as like this. So discussion, majority of the depressive patients, 35 belongs to the age group of 30 to 45 years. This finding is similar than the study done in the Ghosh and others. Occurrence of depression is more in females followed by male. This finding is similar to the study done in Nepal by Banerjee, who reported that 44.7% and the female 55.3%. Similar findings were also found in the study done by the others. The majority of the patients were Hindu religion, 86%, followed by the Buddhist and Christianity. Depression was most commonly seen in a housewife. Higher secondary students were most suffer from the depression than the others. Among the psychotropic medicine, antidepressant 34% was most commonly prescribed medicine, followed by benzodiazepine, anxiolytics, antipsychotics. Similarly, among the different class of antidepressant, SSRI, atypical antidepressant, and TCA were the prescribed. Essential drugs for the depression were prescribed by only 31%. Only the physical functioning of female was higher than those of male. Other variables of mental health like this, RE and RP, mental, bodily, social were obtained in higher in male than that of female. Similar findings were reported by the study conducted by the De Silva. Similarly, we also see some of the things during our study, like there is many drugs we found like unregistered medicine in the market, in that hospital particularly. Similarly, the rate of the medicines is higher than the other places. Similarly, the original price was 100 rupees, but it is quoted 125 rupees. But today's condition, we found it is not very proper during these studies. It is very poor, as we means. We found many drugs are similar in the names, and it sounds like similar, like NZID and MZID. MZID is the total different drugs than the NZID. And similarly, we found the strength, different strength we got, but the strengths are different, 500 mg, but in the similar rackets, similar place, it is kept like 25 mg fit. These are the. Similarly, we found in this is the Indian brands. It is available here, but the same types of the stickers in the both, but drugs are the different. We found the similar name like midazole and midazole. If you can see here, then these all drugs are there. One is the itraconazole, that is antifungal. Another is antimicrobials, that is the propotent pump inhibitor. There is the albendazoles. Similarly, there is some fake medicines also we obtained during our survey. We found the prescribed drugs is prescribed chlorpropamide, but it is given the chlorpropamazine. It's a big mistakes. So there is some of the mistakes we found. Another, we found the misleading labels are there. The brand names are in big and generic names are in small letters. Prescription was not very clear. That is the another things we found. Prescription, we got the prescription, but it is not understandable. Well, outside of the hospitals, we found the many people are selling the drugs. We also found such types of the injections are available in the suites during the market surveys. So we found some adverse drug reactions with the amlodipines, with other drugs also. We also got some of the adverse drugs during our study periods. These are some of the findings. These are the some of the findings. These are the some of the findings we got during our studies. This is the one of the levofloxacin. We got it. These few cases we got it. Lastly, we got this toxical endodermal necrosis due to dapsons also. So the conclusion of my study is the prescribing pattern observed correlates with the changing trends in the treatment of mental illness. Thus, the SSR were the preferred over others because of their better side effect profile. The issue of the prescribing by brand name should be addressed. Quality of life of male was better than female. Thus, such a continuous monitoring of the prescription pattern helps to understanding the changing trends in the prescription in this study. So I would like to express my grateful appreciation to organizing committee, Research and Education Center of Bridging Asian Mental Health and Psychiatry REBAMP for this opportunity. I'm thankful to Professor Hui Shang, Professor, Department of Psychiatry, Tainan City, Taiwan. I'm thankful to Lucy, Executive Secretary, REBMP. I'm thankful to all the dignitaries, speaker, poster presenter, and people of Taiwan. I'm thankful to my research student, Mr. Sundar Adhikari. I'm thankful to Pokhara University. These are my reference. Thank you.
Thank you for Professor Khan's presentation. And the next speaker is Dr. Zhong Wan. Dr. Ng is a MD and PhD. He is an associate professor and consultant psychiatrist in University Malaya Medical Center. He is also the deputy president of Malaysia Mental Health Association and editor-in-chief of Malaysian Journal of Psychiatry. Today, Dr. Ng is going to present the perception of involvement in clinical shared decision-making among patients with depression. Okay. And Dr. Ng has a video, and now we will play this video.
大家好 a very good afternoon. My name is Ng Chong Guan. 我的名字是王章元 I come from Malaysia. Thank you, Professor Yang, Lucy, and the REBAM committee for inviting me to give a talk at this prestigious event again. Today I have selected a topic that is, I would think, quite appropriate or relevant to the current situation. The topic of my today presentation is the impact of COVID-19 pandemic on patients with depression in Malaysia. In early March, there is an upsurge of cases of coronavirus all over the world. This causes WHO to announce or declare COVID-19 as a pandemic. It is a term rarely used by the WHO. As a result, it causes unreasonable panic and fear. Back in Malaysia, I believe, similar to the rest of the world, it has created maladaptive responses among the public, such as inflated estimate of the threat cause, probability. They become hyper-vigilant. They have some dysfunctional, maladaptive behavior. They have heightened reactivity to threat uncertainty. Back in Malaysia, we see people stocking up their food, even tissue paper, even certain goods that we seldom people buy in the supermarket. At the same time, we published an article which named Pandemic in Light of Pandemic in the Malaysian Journal of Psychiatry. Subsequently, we see there is a rising of anxiety cases among the public, such as anxiety disorder, post-traumatic stress disorder, obsessive compulsive disorder. People start to worry repeatedly, they wash their hands repeatedly. There is also consequences of social isolation. People become quiet, agitated, depressed, feel hopeless. Somehow, in the contrast or opposite of the negative impact, we do see some positive impact during this pandemic. We can see there is better compliance of supervision of medication because most people are staying at home, family member are around, partner, wife, husband are around, children are around, so the supervision of the medication are improved. We also can see the strengthening of family support, cohesiveness. We also see there is a reduction of substance-related psychiatric cases admitted to the hospital. In summary, we managed to publish a review article or a brief communication in the same journal, the Malaysian Journal of Psychiatry, which named Impact of COVID Pandemic on Mental Health in Malaysia, a single thread of hope. Back in the mainland China, where the COVID-19 first discovered, they published an article on the association of depression and anxiety with social media use. They discovered that the depression and anxiety was about 17.8% for those who spend minimal time on social media on COVID-19 related news. Somehow the percentage surged to 28% for those who spend more than an hour on the COVID-19 related news. In the same study, they discovered there are three main psychosocial stressors. Mainly, they are worried about themselves or their loved one being infected by COVID-19. They are also worried about their income, job, study being affected by the pandemic. Lastly, everyone also worried about home quarantine will cause great inconvenience to their daily life. Look into another country that is badly hit by COVID-19 in the beginning of the pandemic, Hong Kong. The researcher had done a study among 500 respondents. What they discovered, there is high percentage of depression and anxiety during the pandemic. What we discover is most studies during this pandemic are mainly focused on the psycho or mental health among the general public or the frontliner. It is very unfortunate that what we see, there is no study on its impact on patients with psychiatry disorder. I believe this group of patients are highly vulnerable to develop or worsen their psychological distress during the pandemic. As a result, back in Malaysia, in Kuala Lumpur, we formed a team and do a study on the impact of COVID-19 on patients with major depressive disorder. It was a cross-sectional study. It was conducted back in my university, University Malaya. During the pandemic period, we were unable to do face-to-face interview, so the whole study was conducted through online survey using Google Form. It is started from April, and it took about 2 months to complete the study. These are the measurement tools we used in the study. We use mantras to measure depressive symptoms. We use GAD-7 to measure anxiety symptoms. We use insomnia severity index to monitor the patient's or respondent insomnia symptoms. We also created our own skill to measure on the social media addiction, what we call it, or we give it a mnemonic, SMART. Social media addiction skill for COVID-19 pandemic, SMART. We adapted the skill from Virgin social media skill by doing some modification, expert opinion and trial run, and we come out with the final version of our own skill, what we call it a SMART. At the same time, also we develop a KAP toward COVID-19 pandemic, knowledge, attitude and practice toward COVID-19 pandemic skill. After 2 months of data collection, we managed to recruit about 180 subjects, most of them at young age, about 31 years old. More than half were female, and the ethnicity distribution do represent the Malaysian composition, which mainly consists of Malay followed by Chinese, then Indian and others ethnicity. More than half of those subjects recruited in the study still single. They are not married, and similar to other parts of the world, more than 90% of our respondents using social media. These are the results. It is surprising to find that most patients are having severe degree of anxiety based on GAT7 during the survey. Also, more than half of them still at the moderate level of depression. And also, more than half of them are having moderate to severe insomnia. When we look at the correlation, what we discover, the depressive symptoms of the patient are positively correlated with anxiety symptoms, insomnia, and their addiction to social media COVID-related news, which is measured by the SMART score, the skill we develop ourselves. So based on this finding, I will advise all the implication. We should ensure that our patients are compliant with their treatment. Otherwise, their depressive symptoms will be worsened during this period of time. A lot of them may scare to visit hospital, clinic to collect their medication. They try to off their medication, withhold their medication, just because they lack of access to the supply of the medication. Another thing is, we should look into the concurrent anxiety symptoms. As our study have shown, anxiety is significant or at a high level among the subject with depression during pandemic. What we discover also in the study is their sleep. Most of them having moderate to severe insomnia during the pandemic. Last but not the least, try to stay away from the social media reported COVID-19 related news. A lot of them may not be true, a lot of them may be fake. Try to restrict yourself just to follow up with COVID-19 related news from the reliable resources, government resources, but not any social media related news. Just to share with you the skill we developed during this period of time, SMART score, social media addiction skill for COVID-19 pandemic. It consists of 5 items. The first item is to talk about how often have you thought about COVID-19 related news. Second item is to ask whether you feel an urge to use the social media to search for COVID-19 related news. Third item is to ask about whether you have failed of cutting down the use of social media to look for COVID-19 related news. On fourth item, we ask whether you became restless when you are prohibited, restricted from using social media to look for COVID-19 related news. Lastly, we want to see whether there were any negative impact toward your daily life just because of you are so addicted to COVID-19 related news. And the measurement are on a Likert scale from 1 to 5. Whenever your subject score more than 13, 1, 3, is considered significant based on our pilot study. I think this is a skill that most of us are familiar with. It's GAD7 anxiety skill. It is available online. It can be used to monitor the anxiety symptoms during this period of time among your patient with major depressive disorder. If they score 10 or above, is considered significant. Lastly, remember to monitor the sleeping pattern of your patient during this pandemic period. This is the skill that we use for our study. Insomnia Severity Index. Again, it is available online. It consists of 7 items. The first 3 items is to check for the insomnia problem, whether they have difficulty to fall asleep, staying asleep, or waking up early. Subsequently is to ask about whether they are satisfied, how noticeable their sleep, are they worried or distressed about their sleep problem, or whether the sleep problem have interfered with their daily functioning. So there is a score. Whatever more than 15, you consider clinical significant. So in conclusion, please take good care of your depressed patient during the pandemic period. They are the vulnerable group and often being ignored during this pandemic period. Please advise them not to overuse the social media in searching for COVID-19 related news. Monitor their sleep pattern, and of course, never forget to check on their anxiety symptoms. With this, I thank you for your attention. Thank you very much. Bye bye. 谢谢.
Okay. Okay, thank you. Thank you, Dr. Ngu's presentation. Now, the last speaker is Dr. Chiwasa Surandan. And Dr. Surandan has sent us a video. So, will Dr. Surandan suggest us to play the video, or you will do the live presentation? Dr. Surandan? Would you like to present by yourself, or we need to play the video that you just sent us?
The video would be okay. Thank you.
Okay, thank you.
Good afternoon, ladies and gentlemen. My name is Chawisa Suradom, currently a clinical instructor at Department of Psychiatry, Faculty of Medicine, Chiang Mai University, in the city of Chiang Mai, Thailand. And first of all, I would like to thank the organizing committee for this great honor and for the opportunity to present my research. And as a young psychiatrist, to learn and share from other psychiatrists with more experience and expertise. Hopefully, I'll be able to use the knowledge and experience I gained to improve myself. My research is titled Omega-3 Polyunsaturated Fatty Acid Supplementation for Perinatal Depression, a systematic review and meta-analysis of randomized controlled trials. This research wouldn't be possible without the contribution of my colleagues at the Department of Psychiatry. I would like to thank them for their help, support, and guidance throughout the project. I shall start with the background of my research. From literature review, as we all know, current pharmacological approach of antidepressant still poses the risk of teratogenicity in pregnant women. With a qualitative review in 2018 reported that EPA or eicosapentaenoic acid, a form of omega-3, can reduce depressive symptoms during perinatal periods, while DHA or docosahexaenoic acid, another form of omega-3, can prevent postpartum depression, while another systematic review, a previous one in 2017, however, found insufficient evidence to determine the effects of omega-3 on postpartum depression. With inconclusive results, this systematic review aimed to determine the efficacy and acceptability of the use of omega-3 in perinatal depression, both in terms of treatments and also in terms of prevention. The methods that we started off by searching all the relevant databases, including PubMed, Scopus, Web of Science, clinicaltrials.gov, and the Cochrane Library. We only included randomized placebo-controlled trials that reported the changes of depression severity after the perinatal participants received omega-3 supplementation. We then compared the standardized mean differences after selecting the trials, extracted the data, and assessed the quality of included trials independently. We used the random effect model to compare the depression score changes between the groups. Also, we performed subgroup analysis and meta-regression. And here are the results. We included 11 trials for the meta-analysis and 1 trial for qualitative analysis. The pooled number of participants were 3,181 participants. We found no statistically significant difference between the omega-3 and the placebo groups in the pooled standardized mean differences of depression scores. In addition, we found no statistically significant efficacy of omega-3 either for prevention or treatment in the subgroup analysis, as well as at any perinatal stage, which I will clarify more into that. This figure shows the forest plot of standardized mean differences, and as you can see, there were no statistically differences, and the pooled heterogeneity was 22%, as shown by the I-square. And notably, some of the trials, we separated the study into 2 different groups as they gave 2 different interventions in the trials. For example, different dosage of the same supplementation or EPA versus DHA. As for the risk of bias, we assessed using the criteria from the Cochrane book. As you can see, there was a much higher risk of bias, and the EGOS regression test for the funnel plot asymmetry revealed no significant publication bias of all the comparisons as well. For the subgroup analysis of the perinatal stage, we used classify all the trials by using the initiating point of the supplementation and classify them into first trimester, second trimester, and third trimesters, as well as postpartum period. And as I mentioned earlier, the subgroup analysis revealed no significant difference. And no significant correlation between the efficacy of omega-3 and the daily doses of DHA, EPA, or DHA plus EPA from the meta-regression. However, no trial reported any serious adverse effects of all these supplements. All in all, our research pretty much concluded negative results or inconclusive results, which we may suspect that they're from the limitations of our research, which included small sample sizes of all the trials and limited numbers of trials, especially in some subgroup analysis. Some of them only included one trial, for example, the second trimester of starting point. And there was a lot of missing data on mean gestational age, hence we have to use the classification into trimesters and postpartum period. And we also used the splitting the shared group method into trials, which consisted of different interventions. This may alter the results of the study as well. On a bright side, there were low risk of adverse effects and low costs as well. And there were other outcome benefits, which included preterm birth, perinatal death, neonatal care admission, and low birth weight complications. So to conclude the results of the study, even though there was insufficient evidence to determine the benefits of omega-3 supplementation for perinatal depression,
excuse me. Excuse me, Dr. Surendra.
yes.
I'm sorry, is the presentation ended?
Oh, okay. Is there any problem with the video?
Or there's some problem of the video?
Okay, I see. There's just a little left over the presentation. So I just would I would like to add that even though it's the results of the study concluded that there might not be any benefits of the supplementation on the perinatal depression, either treatment or prevention. It should not deter the clinician to be advised against giving the supplementation in candidate pregnant women due to the fact that the adverse events are very low and the costs and the benefits may outweigh the risk. And I think further investigations and further exploration into the efficacy and studies with larger sample sizes might be very beneficial in the future. So future direction might add more information to this topic. And I think it still remain a promising choice for perinatal depression. Thank you.
Okay, thank you, Dr. Surendran. Thank you for your presentation. And we have about 10 minutes for audience. Is there any question from the audience? I'm sorry for the technical issue.
That's totally okay. Thank you very much for organizing this. Okay.
Okay.
Hello.
Hello.
Hello. I'm Dr. Rashmi from India.
Yes.
My question is to Dr. Suradam.
Thank you very much.
Hello.
Hello.
Are you able to hear me?
Yes. It's not quite clear, but yeah, I can hear you.
Okay. My question is to Dr. Suradam. Regarding the first line in the slide which she has put, she has reported that antidepressants has got potential therapeutic effects. What about the effects of depression on teratogenicity? If we keep the depression concentrated during pregnancy period, whether it has got more teratogenic effect as compared to the usage of antidepressants. Second important question to her is that she has told that there is no benefit of PUFA in peripartum depression. But at the same time, what Dr. Suradam is reporting that one should give PUFA in spite of no benefit. How what is her take on this?
Some parts were missing, and I just want to make sure that I get the question right. You asked what is my opinion regarding giving the supplementation regardless of the evidence that shows no benefits on the outcome of depression. Is that correct?
Yeah, yes.
Okay, thank you for the question. I think my take is that given the very slight chance of adverse effects and the reported adverse effects only results in later than gestational age in very limited cases. So I think it is up to the clinician's decision to consider prescribing the supplementation. And the message should be clear, though, that it may not prevent the mother from having perinatal depression, but in other outcomes, it is proven that it can be beneficial. So if the patient wants to be prescribed the supplementation and there is no contraindication or any risk benefits to that, I think it would be wise not to advise against that or even endorse the patient to take the supplementation given other health outcomes. But on perinatal depression, as of now, I wouldn't suggest otherwise. I wouldn't suggest the benefits of it from the evidence.
Okay, thank you so much.
Okay, thank you for your question.
Okay, thank you. Are there any questions for Dr. Ro or Dr. Kong or Dr. For the speakers?
Yes.
Is Dr. Kong does Dr. Kong have any question?
No.
Thank you. May I ask a question for Dr. Ro?
Sure.
Dr. Naran Ro, okay. You used two different tasks in studies of oxytocin and studies of vasopressin. I'm curious about why you choose two different tasks to measure the social cognition.
So the reason was primarily based on a literature in healthy individuals. The effect of oxytocin on risky cooperative behavior is not examined in healthy individuals as well. But there was one study which suggests that vasopressin is beneficial in improving the risky cooperative in healthy individuals. So that was the reason to choose vasopressin for the risky cooperative behavior. And there are enough studies in literature to suggest the oxytocin is helpful to improve trust behavior in healthy individuals. So we chose based on the existing literature in healthy individuals, so that we wanted to see whether we can extrapolate those findings from the healthy to the patients. Otherwise, there is no specific reason to choose these tasks.
Okay, thank you. May I ask Professor Kong? Kong, you have done a survey on the patterns of prescribing psychotropic medication in your country, and can you tell us more about the clinical implications?
Yeah, well, actually, we studies this in the hospital. So there is the hospital pharmacy is there. So that we looks actually the prescribing patterns from the prescriber, and we see actually what are the different drugs they prescribe, and what are the different brand names, and what are the generic and essential. There is a lot of clinical complications. See, our result shows that brand name prescribing is very higher. So we found that if we can prescribe the drugs in the generic, that it might be very useful for the patient. Similarly, if we use the essential drug list, our country, and might be this drug is available for all the patients, otherwise it is not possible. And frequently they are not prescribing the drugs from the practitioner view. Sometimes there is a pushback, means there is a medical representative, they are giving the pushback. That's why such types of result emerge.
Okay, okay, thank you. Thank you for your answer. Okay, does anyone have questions? So is Dr. Ng Jong-wan is online? Is Dr. Ng Jong-wan online?
Yeah, that's right.
Oh, okay. Good afternoon, Dr. Ng.
Sorry for joining late.
I'm interested about your presentation on the survey of COVID-19, the impact of COVID-19 on psychiatric patients, but I'm not very clear about your psychiatric patient, about their diagnosis. Are they all depressed patients, or they have different psychiatry diagnosis in your survey?
Yeah, I only focus on patient with depression. I didn't take any other type of patient. We only focus on those patients with depression.
Okay, with depression. Okay, thank you. So have you done other studies on different diagnosis of patients, such as schizophrenia or other mood disorder patients?
No, so far the impact COVID study back in my center, we done on 3 groups. The public, but the impact of COVID on public, there are so many publications, so I didn't share with you all today. Another group we study is on cancer patient. So we hope next time we hope that I can share the finding among the cancer patient, the impact of impact of COVID and cancer patient.
Okay, thank you. I think that must be some very interesting finding.
But we are still working on the data. Yeah.
Okay, thank you. Okay, because of the time, it's time to close our symposium. And thank you for all the speakers and for the audience to join our symposium. Yeah, in next next Saturday we still have another symposium and a keynote speech, and welcome everyone to join us in next Saturday. And thank you for joining us today, and I wish all of you have a good day. Goodbye. Thank you.
Bye bye. Thank you.
Thank you, madam.
Bye bye.
Thank you.